Hi and welcome to another video from the CTAD Clinic. My name's Dr. Mike Lloyd and I'm the Clinic Director. In this video what we're going to be doing is continuing the series looking at comorbid conditions with dissociation. So what that means is that other conditions, other diagnoses of psychiatric and mental health conditions that might be confused for dissociative conditions related to complex trauma. And what we're going to be doing in this video is looking at specific examples of what happens when alters might switch or exert influence on a person or an individual system that could then be confused for another condition if someone sticks with that diagnostic criteria. So within the two conditions that we're going to be looking at for dissociation, which is Other Specified Dissociative Disorder and Dissociative Identity Disorder, OSDD and DID respectively, using those and using examples of those from clinical practice and just sort of conversations with people about what can happen and when alters sort of manifest themselves within these internal dissociative systems, and which ones of that type of presentation then could be actually related to other conditions that we've been talking about and which diagnostic criteria might be relevant. And this is really important because lots of people do get misdiagnosed before they arrive at the process of a diagnosis of a dissociative disorder. And we know that the numbers of this is say sort of between 4 and 6 different diagnoses that people get to before they're actually diagnosed with something like OSDD or DID. And when we think about why this might happen, it could be that they've got the two different conditions occurring in the same place, or it could be that the type of dissociation that's presenting itself is being seen and thought to be a completely different psychiatric condition. And actually having an understanding of how that can happen can make it a lot more straightforward for people, whether they're diagnosticians or whether they're people with that condition, to actually understand what that process is and maybe, just maybe, get the diagnosis done better the first time round. I'm going to be talking about symptoms then. So a presentation of dissociation, so an alter coming through or influencing from behind the scenes, as with OSDD, is a symptom of dissociation. And I'm not demeaning or I'm not trying to be disrespectful to any parts alters or anything like that who might be listening in on this and part of dissociative systems. We're thinking about diagnostic criteria here rather than the meaning of what's going on. So this is more about the observable stuff that a person might experience that can then be translated and described to a clinician who then makes a diagnosis. So just keep in mind that that's why I'm using this kind of language. It's very clinical diagnostic type language. To start with then, we're thinking about the type of circumstances that an alter might take over and change the sort of behaviour of an individual person. This is about moving away from the normal. So it's a shift in presentation, and part of the DID criteria is that this can take place and it's a sort of like a shift away from normal functioning, and it's quite different to what would ordinarily be seen in that one person. So if we think about the types of switches that can take place, we can have some of these as examples. So I'm going to go through some examples of this and then we're going to look at how this might manifest in different conditions. Okay, so what we start with then is an alter shifts to the front and changes the position of that person, changes the behavior of that person away from the normal. And that can be quite impressive, right? It can be quite a really observable phenomenon. So a person could be heading in one direction, doing one thing, and then quite suddenly they've gone in a completely different direction and they're doing something completely different. So it's a shift of activity. So let's say, for example, a person is just sort of walking down the street and something happens and they might get triggered. An alter comes through and they might go to a completely different place and they might get on a bus and then they might drive and they might, take a journey somewhere else. It could be miles and miles away, or they might suddenly go into a restaurant or a bar or a pub and start eating or drinking or shopping, or they might just go straight home and then hide under the bed, for example. So these are things that can happen within DID when an alter comes through, especially if they're triggered and they're scared or they're anxious, and they direct the behavior in a completely different direction. Now, for DID, that's a fairly common experience that many people have. So how can this actually get manifested in different diagnostic criteria? And here's how this can work. Examples within, say, borderline personality disorder then would be the two of the 9 criteria that exist. So one is about impulsivity. So a person is doing one thing and then suddenly, often without much rhyme or reason, they go off and do something else. And this can happen a lot, and it could end up with a person being seen to be quite impulsive, that they're making a change, they're altering their behavior without a great deal of thought, without a great deal of planning. They're just often doing it, and they could be off spending money or eating, drinking, going home, not going to work, or doing loads and loads of different things, and it seems to be quite impulsive. So that ticks that criteria of impulsivity for borderline personality disorder. We also have self-harm. Now, we also know that within dissociative identity disorder, within these complex trauma disorders, self-harm is very, very common. And so what can happen is an alter can come forward and start attacking the body, often as a form of punishment. It's a form of retribution. It's not self-harm in the way that we would necessarily consider it to be, often as a means by which to regulate difficult emotions. It's often got much more of a punishing, retributive type quality to it. However, the marks and the actual observation and the presentation of that self-harm would trigger the second criteria of the borderline personality disorder diagnosis under that category. So an alter coming out, changing behavior, doing some of these things can trigger 2 of those diagnostic criteria for borderline straight away. We jump then onto bipolar disorder, and we have 2 different criteria of bipolar disorder that are also met when alters switch and go and do a whole load of different things. First one is about changing goal-directed behavior. So people with bipolar disorder have a very intense focus to get certain things done, and it's part of the manic element of the bipolar condition. A person then is, over a period of time, changes their behavior and becomes quite driven and quite purposeful towards a specific set of goals, in exactly the same way that alters are within the action system theory of structural dissociation. They become quite blinkered, quite focused, and they may not stop until the job is done. And that's one of the criteria. And the second criteria is the sort of the spending and the destructive quality of this, the outcome of that behavior, and then the sort of negative consequence from that person's life. And we know in DID that spending sprees or gambling or addictive type behaviors can have a very, very destructive element, and that is exactly the same. So an alter can come out and they could be spending loads and loads of money, buying all the sort of things that they need to fulfill their own internal need as a result of their complex trauma, and that would fulfill the criteria for bipolar disorder, that over a period of time all of this impulsive behavior is taking place and it is leading to negative consequences for that individual. So here we have alters sort of presenting themselves within DID, doing these very, very straightforward action system type triggered behaviors, could also set off the criteria for borderline personality disorder and for bipolar. Now, more would need to be present because both of those require more than 2 criteria, but it gives you an example of how simple it is to make a mistake when you're actually looking at what the person is doing without realizing that actually it's a manifestation of DID. And it's quite confusing to think that it could easily be a completely different condition that gets diagnosed. And I think that's what does happen a lot of the time. Okay, so that's us looking at dissociative identity disorder, DID. So I'm going to stop the video there, and we're going to have an overview in the second video, which is going to be looking at OSDD in more detail along the lines of the same criteria. And the important thing to do, just to reflect on this process so far, is that what we're trying to establish is that the manifestation of symptoms of one condition, if not properly understood, can look very, very similar to the diagnostic criteria for a completely different condition. And clinicians who don't have the understanding of dissociation are likely to go for the ones that are more familiar to them, like borderline or bipolar, for example, and much less so for the dissociative conditions, which kind of get bumped to the side, or they may not be on the table at all if that clinician is not really versed in exactly what dissociation is all about. And it's so easy to do that because without this understanding of the internal world and how that might be doing, everything just comes down to the presentation on the outside. And if the person's not able to explain why a certain thing might be going on, or have their knowledge about the inside world, or know that that's something that they can even talk about, or they can't overcome the shame and they're not able to talk about it because they're so embarrassed, or they think they're going to get locked up for being crazy if they start talking about internal worlds, then the entire discussion around dissociation remains absent from the diagnostic table and the wrong condition can be diagnosed. So as I've said previously, however, the two conditions can exist in the same place at the same time, but if they are in the same place at the same time, i.e. they are comorbid, you've got to be able to treat both correctly, not just work one and not the other. I think a lot more times though that people are being diagnosed with one condition when it's actually a dissociative condition because the dissociation is not as well understood. And in the second video on these lines, we'll look at OSDD and we'll look at exactly how these symptoms can manifest themselves and what different criteria can be present that can make the mistake of a different diagnosis coming in when it shouldn't be. And hopefully you'll watch that one. So do all the usual sort of things, and please like, subscribe and share and leave comments on the video. And the second video will conclude this mini section on just making mistakes and what happens when alters switch through and how confusing that can be for clinicians. So in between now and watching the next video, please do take great care.